I would like to thank you for the opportunity to present the results of our study today. This study is sponsored by the Research Foundation Flanders. We have no other affiliations to disclose. Colorectal cancer is the second most common cancer in women and the third most common cancer in men. Nearly 40% of these tumors are located in the rectum. Standard of surgical care is a nerve and sphincter sparing total mesorectal excision. This technique consists of excising the rectum together with a total mesorectal envelope. By performing a TME, the rectal reservoir as such is lost, and different techniques have been described to allow reconstruction, such as a straight coloanal anastomosis or a type of rectal neoreservoir reconstruction, a colonic J-pouch, or a side-to-end coloanal anastomosis. However, negative consequences, such as a wide range of bowel symptoms, remain present in the majority of rectal cancer patients. These bowel symptoms are frequently referred to as LARS, also known as the low anterior resection syndrome. Next to bowel symptoms, postoperative physical activity also remains decreased. The aims of the present study were to assess the impact of the type of reconstruction and bowel symptoms on total physical activity levels, sports, occupational, and household activity levels of rectal cancer survivors preoperatively to 1, 4, 6, and 12 months after surgery or after stoma closure. Patients who had a TME for rectal cancer between January 2017 and February 2021 were eligible. After consent, physical activity was evaluated using the Flemish Physical Activity Computerized Questionnaire, the FPAQ, which has been proven to be a reliable and valid questionnaire. The FPAQ was filled out concerning the preoperative period and at 1, 4, 6, and 12 months after surgery. From the FPAQ, total physical activity level, sports, occupational, and household activity level were calculated. To evaluate bowel symptoms, patients were asked to fill out the LARS questionnaire and the Groef questionnaire. Information on the reconstruction type was gathered from patients' surgery reports. The influence on these parameters was investigated at different time points for type of surgery and bowel complaints. A linear model for repeated measures was used to evaluate the evolution of various continuous variables over time and to assess the relationship between the predictor variables and the outcome variables. In total, 125 patients were included in this study. Mean age for all patients was 58.5 years. A straight coloanal anastomosis was used in 58.4% of patients, a side-to-end anastomosis in 26.4%, and a J-pouch in 15.2%. Bowel complaints according to the LARS and Groef questionnaire are presented in this table. Scores on the LARS and Groef questionnaire were highest at 1 month after surgery or after stoma closure. Total activity levels decreased significantly and remained lower than the preoperative values. Occupational activity levels also decreased significantly and remained lower than the preoperative values up to 6 months postoperatively. Sports activity levels were significantly decreased at 1 and 4 months compared to preoperative values. For household activity levels, no significant results were found over time. The analyses showed no significant interaction between time and type of reconstruction on physical activity levels. However, there was a main trend showing better total physical activity levels for patients with a side-to-end coloanal anastomosis compared to a straight coloanal anastomosis or a J-pouch. Concerning bowel complaints as represented by the LARS score, no association was found for any type of physical activity level. A higher score on the Groef questionnaire was significantly associated with time for occupational activity level at 4 months postoperatively or after stoma closure. Furthermore, a main effect was found between the Groef scores and total physical activity level, indicating higher score on the Groef questionnaire was associated with lower total physical activity level. For every increase of 1 point on the Groef score, the total physical activity decreased with 0.24 med-hour per week. To the best of our knowledge, this was the first study to investigate the evolution of different levels of physical activity and predictive factors during the first year after TME for rectal cancer. Total activity levels decreased and remained lower than preoperative levels in the first year. Occupational activity levels decreased in the first half year, and sports activity levels decreased in the first 4 months postoperatively. The type of reconstruction and the LAR score had no significant influence on postoperative activity levels. However, higher scores on the Groef questionnaire indicated lower levels of occupational physical activity at 4 months. Furthermore, higher Groef scores were associated with lower total physical activity levels in general. To conclude, the results of this study showed that not all preoperative physical activity levels were required in rectal cancer patients within the first year after surgery or after stoma closure. With this in mind, patients should be steered and supported in their efforts to resume their physical activities after rectal cancer treatment and guided in their treatment for bowel symptoms. Thank you for listening and sharing this online experience with me.